All right. Good morning. We'll keep a watch out for others to join. My name is Joseph Zalkin. I'm the Executive Director of the North Carolina chapter of NAEMSP, and we're happy to have with us Dr. Tripp Winslow. And David Ezell from the State Office of EMS, and Dr. Daryl Nelson will be joining us. Also on the line is President of the North Carolina chapter of NAEMSP, Jeff Williams. Our program today is going to be about the new ketamine use in North Carolina, approved by the North Carolina Medical Board. We've got a good number of folks, 63 so far online. We will make it interactive as we finish with the formal presentations. If you have questions, if you'll get oriented to the controls with Zoom, your mute control is in the lower left-hand corner on a computer. Your chat box is where we want you to ask questions. So if you'll ask a question and leave an email address, that all gets encoded with the recording that we've got. And then if we don't follow up immediately with it, we'll follow back up after the program. So you can open that chat box up and slide it off to the side. Got a few more popping in. If you, like I said, if you have questions, please put that in the chat box. You can type it to everyone. And if you'll leave us your email address, that's helpful. For those on the phone, if you'll follow up with the email that you received when you registered, if you have questions, we'll route that to the appropriate folks. At this point, I'm going to turn it over to David Ezell from the State Office of EMS.
Thank you, Joseph. I'm going to get this moved over here. All right, can y'all see my screen now?
Yes.
All right, so I think the idea was that basically I would give an update, kind of the background as to how this thing got started, kind of what transpired with the medical board, and kind of where we are today and where we see this thing going, moving forward. Let's see if I can get this thing to, there we go. All right, so we first went to the medical board back in September of 2016 trying to get ketamine approved. As you can see, this is a 4-year process just to get to where we are today. They approved a pilot program back in May of 2018. Basically, it was a 1-year pilot program where they wanted us to do some data collection and just analyze whether they felt the drug was safe. I think there was a lot of concern from the medical board, particularly from a lot of the providers on the board who were not familiar or comfortable using ketamine in their own practice, and they had some questions about that. So that's why we went forward with this pilot program so that we could try to get some data for them. So we launched that pilot in November of 2018. Here are the requirements to participate in the pilot program. Basically, all the programs had to be approved by Dr. Winslow. They had to adopt the state protocols. They had to get letters of support from the hospital. They had to provide some standardized training to the personnel. It had to be included as part of peer review. All the data had to be reported back to our office, and then every single administration was reviewed by the local EMS system, by our OEMS staff, and then by Dr. Winslow as well. Here's a list of the programs that did participate in the pilot program. You can see we've got folks from all across the state. We've got a mix of hospital programs, government programs, nonprofits, a mixture of some of everybody all across the state. Here's just many of you are familiar, but NAESMP and Dr. Kitch put together a training video that was available for all of the programs to utilize. About a 20-minute video to explain kind of the background on ketamine. A lot of the programs utilize this as part of their training program across the state. Here are those dreadful forms that everybody had to fill out for every single administration across the state. So we had 2 different forms. We had one, the form on the left was the EMS form, and that was every crew, whenever they would administer the medication, they had to fill out the form on the left. The form on the right was for the hospital to fill out and report back to the EMS system to basically provide some follow-up information so that we could kind of track the patient through to see where they were. And for every one of those administrations, we were getting these forms as well as the EPCR. So you can see over the course of the year, here's the breakdown on the data where the administrations across the state. You can see that it was basically given 302 times in the course of the pilot program that we reported back to the medical board. And again, this is just looking at the pain and excited delirium behavioral protocols. This is not including any of the systems that utilize it for airway. So this was kind of what everyone was wanting to know, particularly at the medical board, were the adverse reactions that we saw from that. So out of those 302 administrations across the state, we had 1 field intubation, 6 hospital intubations, and then 9 times the patient was bagged. So we felt pretty confident about this information. Just as kind of side notes, the field intubation was a patient that had received multiple benzos and other medications, had some psych issues going on. You know, a lot of these things we saw, a lot of the hospital intubations were similar to that as well. And then we also had a few that had multiple trauma patients. So a lot of these people probably would have bought a tube regardless of the ketamine, but at least we did want to report that information back to them. We did learn, obviously, a few things from doing this out of that. So one of the things we learned was on the IM dosing. So they were given, 400 milligrams IM for that excited delirium patient. Well, obviously, different medications and different concentrations, depending on what they were getting, they were given 2 to 4 mLs IM, and they're like, well, we can't do that in a single injection, so now we're having to give multiple shots to the patient. So definitely some things that the systems had to take into consideration when they were looking at the concentration of the medication they were buying. I mentioned the mixing of medications. We had those few patients that did have some unusual outcomes or different effects from the medication. A lot of those did have multiple substances on board already prior to EMS interaction, and several of them received Versed and ketamine from the EMS crew, or Ativan and Versed and ketamine. We definitely noticed that when they were getting multiple medications back to back to back, then it definitely seemed to decrease the respiratory effort. So obviously something we needed to pay attention to. And then obviously closing the loop was another thing that we had to focus on. And there was a lot of documentation required to participate in that pilot, and getting that documentation back, particularly in a timely manner, proved difficult at times. And I could definitely see where some systems would struggle with this, and we recognize that. So Dr. Winslow and I met with the medical board a few weeks ago, and then finally on the 28th of May, they provided us approval to use the medication, to use ketamine in the formulary. They did have 2 stipulations to use the medication. For anyone under age 12, they want online medical direction for those patients, and they still want us to mandate the hospital approval letter from anyone that wants to do that. So we appreciate them working with us and going through this. It's been a long process, and we're glad to kind of have this behind us and try to move forward. So moving forward, kind of I think what we're trying to do is obviously, I think there's some updates to the protocol. Dr. Nelson and the NAEMSP crew have been working hard on trying to get that updated. We've obviously got to update some of our data collection process, and we've been trying to figure out what exactly do we at the state still want to collect. And we're also looking into, hey, this is some valuable information that we've been able to gather here. When we first put together this thing 4 years ago, we were trying to do a literature review and find information on ketamine use in EMS, and it was difficult. So obviously we're thinking maybe we need to put some of this information out there into some publications. So like I said, NAESMP has worked on creating some new protocols, updating the protocols. Dr. Nelson may be on at some point to try to talk about those, but I am just going to hit the highlights on that. He did update the behavioral protocol. It's been totally redone. But you can see now that ketamine is included as part of that, and he'll go over the details as far as how that's being used there. We also did some updates to the pain control protocol. You can see in the moderate to severe arm down there, we do have ketamine now as part of that protocol as well. We've also updated those pearls, particularly in that pain protocol. And you'll notice some caveats down at the bottom about avoid use in combination with benzos due to that decreased respiratory effort, which was, like I said, several of those patients that we did see some side effects from the respiratory depression. A lot of those were getting multiple medications there. So what we're looking at right now, and we're still trying to figure this out and get these things moving, but part of this is to participate moving forward. Obviously, you're going to need to utilize the NAESMP protocol whenever that's adopted. We're going to need those letters of support, just like the medical board said. Obviously, with anything that we do, we want to make sure that our personnel are trained appropriately. We still do want to include ketamine as part of peer review, and that peer review process includes the hospital feedback on that. So whereas before you were getting a hospital form on every single administration, I think our thought process now is that as you include ketamine as part of peer review, the hospital will report back those cases that did have adverse effects and include that as part of the peer review. And we do still want to collect some data on that, but we're going to try to simplify that process. The way we're trying to look at doing that is we utilize a program called ReadyOp here at the office. We started using that quite a bit here in the last year or so, and it's been particularly helpful during the COVID event here. So basically, it's just an online link just that you would go to and fill out a form, and we've got two forms. Basically, the one form is for the provider whenever there's an adverse outcome being described as a cardiac arrest or an unanticipated intubation. And basically, they need to fill out the link and provide a copy of the PCR within 14 days for any of those that meet that criteria. And then there's another link for the EMS system to use, and it's basically a quarterly link that they would go in and say, these were our total number of administrations, and these are the highlights from the peer review. Obviously, our OEMS staff does try to attend most all of the peer reviews that they can, but obviously they're not at all of them. So we just want to make sure that we do get that information and we're able to collect that on a state level. I think it'll also be a good way as we work with ESO that we can go through and make sure that the number of administrations that you're saying as we look on the backside through the state repository to make sure that all of that matches up for audit purposes. And again, here's just a sample of the link from ReadyOp. It's literally just you click on a link, go to a website, fill in the boxes, hit submit, and the data is submitted straight to us from there. And we can run the reports that we need to out of that. So with that, that's my contact information. I don't know if Dr. Nelson was able to jump on just yet, if he wanted to go over the protocol, or Joseph, you may turn it back over to you.
Yeah, I don't see Daryl yet, but we do have some questions in the chat box. If you want to take a glance at those.
Yeah. Joseph, can I say a few words first?
Oh, yeah. Go ahead, Trip.
Oh, yeah. We're just basically, the medical board stipulated that we still have to collect data. We just don't have to send the data to them. The medical board has also stipulated the hospitals still have to signify or indicate that they can receive those patients. So, you know, we definitely want to cut down how much data we're requesting. So I figure the two hardest endpoints you can get is innovation, although unanticipated innovation can get a little bit of a gray area, and a death. Unless they have those two things, I don't think we really need to know about it. And we just want to know about those within 14 days. You know, obviously the EMS agency would submit that within 14 days. And otherwise, we just want to have a good denominator about how many times it's been used every quarter, so we can get an idea of the adverse reactions. As far as the specific protocols, NAESMP is going to come out with some standardized protocols. Daryl has been working with the NAESMP EMS committee to make a lot of adjustments to the behavioral protocol. But whereas before we didn't allow any changes to the protocols for ketamine, you know, we will allow changes to that to those protocols. They still obviously have to be submitted through a system modification. And then the medical board just said you have to have online medical control if you're going to give it to anyone older than 12 or just basically like we've been doing before. Of course, if you don't know the age and they're longer than the Broslow tape, that's also okay. But we definitely want to make the data reporting easier on the systems and get away from that form. And as far as the hospital outcome stuff, we would basically just like the hospitals report every quarter if they had any unanticipated or bad outcomes from patients getting ketamine, so the EMS systems can be aware of that. And really, that should probably be part of peer review, and we'll let every system kind of approach that how they best see fit. But we're definitely happy to get this done. I think the first meeting I went to by myself in 2016, 2017, something like that. Then Jeff Williams and Roy Alls and a bunch of other folks came and helped the second time, and then we kept going through multiple meetings, and finally we had the breakthrough of getting the pilot project. But we definitely want to move forward. And this is ketamine for it's not just restricted to pain or sedation, and we already had it for airway stuff. So it's a full scope. So I think that's an important thing to also remember. And that's all I had, Joe.
Trip, I'm seeing a bunch of questions about the letters. The current letters for the folks who participated in the pilot are good. They don't need to renew any of that. And I'll do a follow-up with that.
Correct.
Is it maybe possible to do a universal letter for receiving hospitals that would cover, a region or an area?
We already have some templated letters they can use, but we are going to make sure that every hospital does have the capability and the monitoring capability to take care of those patients. That was something the medical board stipulated during the meeting.
Sure, I would assume every hospital is capable of monitoring a patient. Any receiving emergency department, but whatever.
Hopefully, but not in my experience, not always. But I think they still need to be aware of that, and that's one thing early on the medical board was very concerned about.
And is that something OEMS is going to keep up with?
Yes, when they do the system modification, my assumption is that would be included with the system modification. One thing we're also going to cut back on is before each EMS agency or system had to submit the exact training program of how they're going to do the training. Now all we want to know is that they're going to train their people, and they don't have to say exactly how they're going to do it. We just wanted them to verify their training, which they should be doing anyway.
Do you see maybe a bulleted email of the steps involved to add this to your program and what's different between the pilot and what you're expecting going forward?
Yeah, I think that can definitely be done. And also the nice thing is we'll be talking with the regional specialists who work closely with all the counties, and they will definitely help them through that process. Because if you look at other medicines like propofol, that was a very restrictive use approved by the medical board, and the regional specialists help with propofol use. Can y'all hear me? It looks like everybody froze. Okay, so there's somebody moving behind Jeff, so it's not frozen. So yeah, the regional specialists can definitely help with that. And we'll definitely give support. But we have other medications that we've done in the past, which are somewhat special, but hopefully we're making this less special.
Very good. At this point, you have control of your mute button. If you want to ask a question directly to the group, if you'll unmute and make sure it's clear, you can ask.
I don't have a question. I wanted to answer one of the questions that just popped, and then also I wanted to take a quick opportunity to say public, or at least close to public as this forum is, thank you to Tripp, Dr. Winslow, as well as David. Obviously several of us have kind of helped out over the years with this, but they've really had a lot of tenacity and patience in getting this done the right way and providing appropriate data to those who really didn't know a lot about EMS practice. So just a thank you. I mean, obviously this isn't a magic drug, and we still have to, make sure that we as individual systems utilize the drugs and the protocols correctly. But just a big thank you for those guys' hard work on this. And the second thing I'll say, somebody asked about education. There was a comment about education that either Tripp or David made, and then I believe Dr. Seibold's asking about canned education for local medical directors, and the answer is yes. So that was actually done to some extent prior to the pilot. So Dr. Kitch has a video that he narrated and was vetted by the North Carolina chapter, at least, and then put out on our YouTube channel.
That's a great video.
And that's an excellent video. I'll just give you an example. What we intend to do here, we're hopefully going to try to roll this out. We have a quarterly education cycle, and so we're hopefully going to try to roll this out in our Q4 education this year, just so we have time to get things going. But as a prelude, just as a quick thing to get together, I'm going to basically record an introduction to Brian's video that was done for the pilot, basically to do kind of what David did and say, hey, look, this was a pilot thing. That's why you'll hear Dr. Kitch refer to the pilot in the video, and just sort of a quick 5-minute explanation on that. But the actual content of the video talks about ketamine pharmacology, talks about its uses for both pain and behavioral patients. So certainly I think folks could adapt that video to their usage for some basic ketamine education, if that's useful.
And Dr. Kitch is working today and couldn't be here, but I did ask him with the modifications with the board, maybe an addendum or an additional video may be forthcoming to make it updated for what's out there. But that's on the NAEMSP YouTube channel. It may be one of the only programs we have on there. I don't recall. I think we may have, the other one is on telemedicine that we did a couple weeks back. So that's a resource, and there is an exam, a test for that as well.
Oh, two other things. I noticed Bobby Portella is also on. He actually attended one of the second to last medical board meetings in place of me. He also did a very good job. And just per Doug Swanson's question, I'm okay if you have a hospital system, which basically says all our hospitals, like whether it be Novant, Atrium, CMC, you get a letter from the hospital system or somebody saying, yeah, all our EDs can take these patients. I'm okay with that also.
Speaking of publications and Dr. Kitch, for those who don't know, obviously, Dr. Kitch recently published an article in JSEP Open about ketamine. And so, and it's basically a review article. And it would probably be very easy to, for Dr. Kitch to just add the data from our state to that article and publish it as our state data. So for those who are interested, definitely need to reach out since he's not here on the call today to get up with him as part of that writing group.
Can you guys add that link to the chat if you have it at your fingertips? Or if not, that's fine.
I'll put it out on Basecamp as a follow-up.
Thanks.
If you want to talk, if you'll unmute yourself, we'll give you the floor. All right, y'all are an orderly group. I like that. So unusual with some of these characters. I just wanted to go back and let you know from the chapter standpoint, if you're an emergency medicine doc or an EMS medical director who's not an emergency medicine doc, NAEMSP is a great supporting organization and it's a great networking opportunity for both EMS administrators and medical directors. Your state chapter is very active, both in advocacy as well as education. This is our third webinar that we've done since COVID hit and we were sort of all at home. I highly recommend that you check out the national organization and our materials, like I said, are up on the YouTube channel that NAEMSP has proper. We will probably do more of these. This is sort of a topic specific group. And I really appreciate, we had a great return on the registration. And if you'll let me know either online or offline, if this is something you want, we will be PDFing David's slides and they will be available on Basecamp. And if you want them directly, I would say contact David direct for use of that. We are recording this. This will all be up later this week. And I will post a follow-up since I've got your email address from the registration, just as a survey to say, how does this work for you? And are there other topics you may be interested in? So I'll go back and say, if you have a question, you can unmute. I'm not hearing anybody. Just for note, there's 72 people online, which is just amazing. Yeah. How do I get up? With that, we'll call it a close. I appreciate your time today. Look for an update in your email and take care.
Thank you, Joseph. Thanks so much for putting this together. I really appreciate it. And it's been great, really great working with everybody throughout the state on this. I think we have a great state and I feel really lucky how this is going to be able to work with y'all. Thank you very much.
Yeah, thank you, Tripp, for all your efforts, David, as well. No one would have thought this would have taken 2 years to get to this point.
I mean, I'm really lucky to be able to work with such great people in this state. So thank you so much.
All right, everyone have a good day.
Thank y'all.